Okay, so let's get started with Module 1.3. We're going to be going over the topic of shortness of breath. So we'll begin with the case presentation. We have a 35-year-old female that presents with dyspnea. Upon questioning the patient, she states that it started approximately 2 hours ago and was associated with pressure-like pain, chest pain that radiates into both arms. Patient rates this pain as an 8 out of 10. Additional signs and symptoms include nausea and diaphoresis. Patient denies cough, leg swelling, vomiting, headache, and dizziness. Symptoms improve with rest and get worse with exertion. Patient admits to having similar symptoms previously when she was diagnosed with a clot. So in this particular presentation, there's 3 key documentation areas that should be noted. One being the associated symptoms. This patient complained of nausea and diaphoresis and denied cough, any leg swelling, vomiting, headache, or dizziness. Better with or worse with. So this is a clinical question we ask patients essentially to kind of weed out and focus on what in our differentials we're actually dealing with. So she states symptoms improve with rest and get worse with exertion. Other things we kind of fish out if someone's short of breath is if they're having difficulty laying flat, if they have to use an extra pillow at night. Are symptoms worse in the morning? Are they worse at night? So previous experience with symptoms, another key documentation area. The big issue with this patient is she admits to similar symptoms previously were when she was diagnosed with a blood clot. So in this particular case, it kind of hones us in as physicians on putting any sort of clot-related diagnosis at the top of our list of differentials. Past medical history. So patient says that she's had no medical history except the clot that's previously mentioned. She has no known clotting disorder. Only medication she's on is oral contraceptive pills. And patient smokes 2 packs of cigarettes a day. She's had no previous or recent surgeries. So in this medical history, what we tend to focus on is what, as far as what the patient's telling us, is going to factor into our differentials. And the major one looking at this is that she's a smoker and she's on birth control pills. This in itself increases the risk greatly of blood clots. So dealing with differentials, at the top of our list is PE, or pulmonary embolism, which is a blood clot to the lungs. Acute MI, acute myocardial infarction, heart attack. Number 3 is aortic dissection. Number 4 is a COPD exacerbation. Now, COPD is essentially emphysema or a chronic bronchitis, and this is typically patients that have a long smoking history, maybe oxygen dependent. This goes in our differential because this patient, despite her being of a younger age, she's a heavy smoker and no known COPD. So always ask your physician for several differentials when you're dealing with any particular chief complaint so you document correctly and you know exactly the line of thinking that your physician's going down. Physical exam findings. Vitals are very important in this patient, as in all patients, because it shows us that the heart rate is 120, which is tachycardic. Anything between 60 and 100 is normal. Blood pressure is 150 over 96. We would consider that hypertensive. Blood pressure 120 over 80 is essentially your gold standard for blood pressure, so this being higher would deem this patient hypertensive. O2 sats are 85% on room air, which is hypoxia. Anything less than approximately 92% is considered someone who is not getting proper amount of oxygenation to their lungs. So physical exam findings, she is older than stated age. She is alert and oriented times 3. On her head, ears, eyes, nose, throat, her mucous membranes are moist. Her oral pharynx, there's no erythema. Respiratory exam, she's got wheezing kind of throughout with accessory muscle use, which means she's just working harder to breathe, whether that's the shrugging of her shoulders, breathing through pursed lips, something that tells you that it's difficult for her to actually bring oxygen into her body. Cardiac exam, she's got tachycardic exam, no murmur, abdomen soft, flat, non-tender. Extremities, so despite the patient stating that she had no swelling in her legs on her HPI, on our exam we find that she's got 2+ edema on her right leg up to her mid-calf, which is tender to palpation with no erythema. So this goes to show, as you know, in any patient that you encounter in an emergency room, that the story may not necessarily match your physical exam or what you may find throughout the emergency visit. So neurological exam, cranial nerves 2 through 12 are intact, muscle strength 5 out of 5 in her upper and lower extremities. So on this physical exam, as a physician, we're very suspicious for a clot now, so everything's kind of adding up. She's had a previous clot. She's a heavy smoker with oral contraceptive pills. Her vital signs are showing she's not getting enough oxygen. Her heart is working harder than normal to pump blood throughout her system. So very suspicious for clot. On this exam, the unsymmetrical swelling of her legs is a key that there may be something going on as far as a clot in her leg that may have traveled to her lungs. If they had bilateral swelling, we think of heart failure, congestive heart failure, or renal failure. So there's a couple different rules out there that we use, one of them being the Wells score. There's a Wells score for DVTs. This is the Wells score for PE. So as we go through this, we assess a point basis. So the criteria, are we suspecting a DVT? Well, yes, because a DVT would mean a deep vein thrombosis that originates in the leg. This patient had a edematous leg that was erythematous and tender. Those are very suspicious clinical signs for DVT. So right off the bat, she's a 3 for points. At the score range, just jumping to the bottom real quick, if you have a 0 to 2 points, it's a low risk of a PE, which is mean probability of 3.6%. 3 to 6 points gets you a 20% probability, which is moderate, and over 6.66% are high. So she's already got 3 points, so she's already based in a moderate risk. Going back to criteria up top, an alternate diagnosis is less likely than PE. At this point, I would have to say no, so she's going to be assessed 3 points, so right there is 6. So she's already hit the high level of risk, 66%. Heart rate over 100, yes, she was 120, that's 1.5. She's up to 7.5 on her score. Immobilization or surgery in the previous 4 weeks, well, she's told us that she's had no surgery. Didn't really ask about immobilization, but she didn't look like the sedentary patient population. She looks like, you know, she's younger and she's still getting around and working, so I wouldn't assess any points for that. Previous DVT PE, she gets another 1.5, so she's up to 9 points. Hemoptysis, we didn't focus in on asking this question, but it's a good question to ask. That's if you're coughing up blood. That would be 1 point, so she'd still be at 9. Malignancy on treatment, treated in past 6 months, that's no. She gave us no suspicion or evidence that she's had cancer in the past or currently. So 9 points, definitely high. I would consider that, you know, definitely higher than even 66%, so we're on the right track. So studies, you'll hear the term D-dimer kind of bounced around the emergency room. When you're dealing with a D-dimer, it's not very specific for patients. It helps if a patient's low risk, and it's just a blood test. False positives occur in cancer patients, obese patients, or pregnancy because those tend to give this level a falsely elevated range. So in this particular patient, a D-dimer would not be very helpful for me as a physician because my suspicion is so high based upon her high risk, based upon our clinical Wells score, as well as the fact she's had a clot in the past, that this wouldn't even be a study that I would consider. Now, other physicians may still do a D-dimer. This is all physician dependent, as all these case studies we go through are. However, we're just trying to give you all the facts and why we order these tests. Troponin is a cardiac marker, something that we've discussed previously. It's obviously always going to be in our differential. We see heart attacks at the age of 21, 30. It really is not an age-related diagnosis for heart attacks. So it's always got to be in our differential if someone comes in short of breath. EKG findings. So there's a term that we may describe to you as a scribe that's an S1Q3T3. This particular term means that there are S waves in lead 1, Q waves in lead 3 and inverted T waves in lead 3. And if this particular finding is on an EKG, there is the approximate risk, I believe, is anywhere from 10 to 15% that there's a chance of a pulmonary embolism, PE. So if all the history, physical kind of add up and you have this EKG, it's just another piece of the puzzle. So EKG, there's also what we call right ventricular strain, which is T-wave inversions in the right precordial leads, which is the V1 through V3 leads. And in this particular EKG, you just see inverted T waves kind of all along those leads, V1, V2, V3. So that can just tell you there's some strain on the heart due to this clot that's sitting in a lung, which is occluding the ventricle from actually doing its job. Other studies that I like to touch on, one being a venous Doppler study. So this particular study assesses the deep vein thrombosis in the legs. That's where clots do originate and they move up to the lungs. So in this particular patient, venous Dopplers would be something that we would consider. However, this is primarily where things originate. And right now it looks like she's got a clot in her lung. So we need to first do some studies to see if our clinical suspicion is right and look at her lungs. And if her lung studies are negative, then we would go to a venous Doppler at that point and see if there is anything in her legs that possibly did move to her lungs that just is not being seen anymore. So that particular study is a CTA of the chest, which is a CT angio of the chest, and that's IV contrast, and we're assessing the pulmonary vessels, looking for clots. So in this particular case, giving IV contrast, we have to make sure the patient has good renal function, because if they don't have good kidney function, we can push them into kidney failure. So if a patient's a dialysis patient, those patients would not be getting CTs with IV contrast because we already know they're in kidney failure. So we have to look for a different modality or test in order to diagnose if they do have a clot in their lungs. That particular test is called a VQ scan. It's essentially a ventilation and perfusion scan. Not sure where the Q comes in, but that's basically it's showing how the patient breathes when they breathe in a radioisotope, and then they have perfusion or bloodstream injection of a radioisotope. And then there's an actual basically scan that we look at the lungs and we see if there's any defect as far as the uptake of that radioisotope in the lung. And if there's a defect, then we know that they're not perfusing that area of the lung and there's possibly a clot there. So the results of this study do not come back and say positive for blood clot or not, because that essentially is not what this test is doing. It would just tell you low probability, moderate probability, or high probability based upon the actual scan. And obviously this requires no IV contrast. So in the medical decision making with this patient, my discussion with the patient would go somewhat like this. I found that you have 2 large blood clots in your lung. As you know from past experience, you will need to be hospitalized and placed on blood thinners in order to dissipate the clots. And kind of going over any questions, do they have any pain, kind of sort of wrapping up our clinical assessment of the patient at this point. In regards to documentation of this medical decision making, which is a very critical component of the chart, the documentation will look somewhat like this. Dr. Perkins informed the patient that they have 2 large blood clots in her lung, requiring admission and IV blood thinners. Patient's okay with treatment plan and has no questions at this time. And even interjecting that patient's pain is appropriately controlled, or if the patient did have pain, that something to the understanding the patient stated her pain is 8 out of 10. Dr. Perkins is ordering morphine for patient at this time. So moving on to our disposition and what we're going to do with this patient. So this patient obviously will need to be admitted. We will admit to the step-down unit or the ICU. ICU is typically where patients go if they're on heparin drips. However, every hospital is different. We would be consulting a pulmonologist if this patient truly was a PE, and even a vascular doctor if DVT was documented on a venous Doppler as being still present. So if the patient has a cardiac arrest secondary to this PE, the patient will need an embolectomy to remove the clot. So this is something that if the clot is large enough, that it will cut off your oxygenation and you will have a cardiac arrest. So in emergent cases, what do? Well, in emergent cases, we'll call for the surgeon to do an embolectomy and go in and actually pull that clot out. So you always want to document telephone conversations between consultants. Ask your provider what needs to be in the chart as far as what was entailed in that conversation between them and the consultant and what's pertinent. So that concludes our module on shortness of breath. I hope that you learned at least something a little further along the lines of how we are thinking when we're dealing with these particular patients, and it brushes up any of the questions that you may have had. Thank you.